Hello everyone. Today we are going to talk about immunosuppressants. Immunosuppressants are the drugs which reduce our immunity. In whom do you need to reduce immunity? Either in a patient who has undergone organ transplant or in a patient who is suffering from lot of autoimmune disorders. Before talking about all these, let us first understand the normal physiological process of immune response. Whenever an antigen is present, our body, with the help of antigen presenting cells and the MHC complex, that is our major histocompatibility complex, combined with the antigen forms a complex. This comes and presents itself to T helper cells. Let us say this is our APC, antigen presenting cell, with the antigen with the MHC. Now it brings the antigen and presents itself to T lymphocytes. There are many T lymphocytes here. One such T lymphocyte is this. Now we need CD4 T helper cells for immune response. What usually happens is whenever a APC with MHC complex comes, it recognizes the CD4 cells with the help of CD3. These CD3 receptors are basically recognition molecules for APC. It is not just mere activation of CD3, it also needs many other co-receptors like CD80, CD86, CD20, and when all these are activated, what happens is there will be inflow of calcium. This calcium, whatever enters, will cause activation of calcineurin. This activated calcineurin is responsible for activation of NFAT. NFAT stands for nuclear factor. Okay, I'll write it here. NFAT stands for nuclear factor for activation of T cells. When NFAT is activated, it results in transcription and translation. This NFAT enters into the nucleus, results in transcription and translation and expression of interleukin 2. This interleukin 2, whatever is secreted as a response to the activation of the T cell, is responsible for, it starts recognizing interleukin 2 receptors which are present on various other T cells, and it goes there. And what does it do? These are interleukin 2 receptors. So what does it do? It starts activating mTOR. What is mTOR? mTOR is mammalian target of rapamycin. Mammalian target of rapamycin. This mTOR, once activated, will result in it enters into the nucleus and it results in transcription, translation, and most importantly, it causes cell division of, what are these? These are T cells. So cell division of T cells as well as differentiation into natural killer cells as well as other macrophages. This is how your normal immune response will be. Now, how do immunosuppressants act? Immunosuppressants usually act by either inhibiting this or inhibiting the CD3 receptors, inhibiting your calcineurin, inhibiting your mTOR, inhibiting your cellular division, as well as there are many other biological many other methods also. Now we will talk about these in detail. So, immunosuppressants are further divided into first one, calcineurin inhibitors. This includes cyclosporine and tacrolimus. Secondly, it also includes mTOR inhibitors. These drugs include Sirolimus and Everolimus. Then your biological compounds. Let us not go into everything in detail, but one is CD3 monoclonal antibody, which includes muromonab. Second one is your CD3 finished, then comes your co-receptors as well as receptor for interleukin. Interleukin 2 receptor monoclonal antibodies against interleukin 2 receptors. It includes basiliximab, daclizumab. At least remember one, that's for sure. And other immunomodulators like interleukin 1 antagonist, anakinra receptor antagonist, anakinra, and most important inflammatory mediator, that is TNF alpha inhibitors. At least remember one drug, that is infliximab. These are the biological agents. Now let us talk about most important and most often used immunosuppressant agent. Those are glucocorticoids and obviously prednisolone, hydrocortisone. Finally, anti-cancer chemotherapy, anti-metabolites. They mainly include methotrexate, azathioprine, and then your mycophenolate mofetil. We will discuss all these together. Like, see, let us first talk about calcineurin inhibitors. They include cyclosporine and tacrolimus. So, in calcineurin inhibitors, what usually happens is, whenever calcineurin inhibitors includes two drugs, cyclosporine and Tacrolimus. This is one of the most important questions quite often asked for 5 marks. With respect to mechanism of action, both will inhibit calcineurin only, but cyclosporine combines with cyclophilin and then it inhibits calcineurin, so that your initial phase of the immune response is gone. In fact, will not be activated. The same here with respect to tacrolimus, but tacrolimus binds to FKBP, that is FK binding protein, plus tacrolimus complex is responsible for inhibition of calcineurin. Clear? Now, let us talk about adverse effects. Most important adverse effect of cyclosporine is nephrotoxicity. Others include, see, there are many, but most important, let us talk. Okay. Others include bone marrow suppression, somewhat, not like your typical, let us not include this now. In fact, hirsutism, gum hypertrophy, these are much more important. In fact, we expect you to write them in your answers. Whereas the adverse effects of tacrolimus, obviously your hypertension, because nephrotoxic, so hypertension is seen. Now, Adverse effects of tacrolimus includes, most importantly, alopecia. Your nephrotoxicity incidence is less, the severity is less, incidence is less, hirsutism is not seen, gum hypertrophy is not seen, hypertension is rare, but incidence of diabetes or incidence of abnormal glucose levels is more with these tacrolimus. Clear? This is about first group, that is calcineurin inhibitors. Now let us talk about mTOR inhibitors. See, mTOR inhibitors primarily act in the late phase of immune response. That is, already interleukin 2 is produced, then only mTOR comes into play. Clear? So this is considered as late phase. There is nothing specific with respect to it. Only thing is, whenever you give sirolimus or with respect to mechanism of action, whenever you give sirolimus or everolimus, for that reason it binds with FKBP, that is the binding protein which is needed for tacrolimus is also needed for sirolimus, FKBP, and this will inhibit mTOR, so that cellular division, T cell response, T cell differentiation, everything will be gone. Clear? But the adverse effects include, these are very less nephrotoxic, but we do see increased incidence of diabetes, all opportunistic infections, and all. Then, with respect to monoclonal antibodies, I feel you need not know much in detail about them. CD3 monoclonal antibody is muromonab. This muromonab, when inhibited, will completely stop the initial response itself. Whereas your next one monoclonal antibody is interleukin 2 receptor antagonist, which includes basiliximab, which acts at a later stage. Then comes your anakinra and TNF alpha inhibitors. There is nothing more to add to this, but with respect to glucocorticoids, you need to understand most certain important points. First thing is, this is fast, response will be seen, but should be given for shortest duration possible. Why? Lot of side effects. Then how do they act? Obviously, glucocorticoids act by inhibiting nuclear factor kappa beta. This is already dealt in your chemotherapy class, for your corticosteroids class. For now, let us restrict ourselves to this. Clear? Because of their faster response and to be given shortest duration, this is used in induction phase. Regarding this, we will talk. And then comes our last group, that is anti-cancer chemotherapy, anti-metabolites. Methotrexate is a folate antagonist and it inhibits dihydrofolate reductase as well as inhibits thymidylate synthase, because of which replication does not happen. Clear? Cell division of T cells is inhibited. Azathioprine gets converted into 6-mercaptopurine and it also inhibits thymidylate synthase. Same, purine metabolism will be gone. Thymidylate synthase is inhibited. Now, we need to know in detail about mycophenolate mofetil. Why is it so? Because this is least nephrotoxic. What happens is, mycophenolate mofetil is a very good drug and it acts by inhibiting IMP, inosine monophosphate dehydrogenase, because of which there will be no guanine. It's the same, it's basically an anti-metabolite, so no cell replication. It's the same with everything, like the rest of the anti-cancer chemotherapy drugs. But the mechanism is different. Inosine monophosphate dehydrogenase is inhibited. This is about individual drugs. Now, let us talk about uses of immunosuppressants. Obviously, first one is organ transplant. In a case of organ transplant, what usually happens is we give induction therapy, which is started in fact prior to transplantation, and maintenance therapy. This is given throughout the life. Induction regimen usually includes corticosteroids because they are fastest acting immunosuppressants, and usually we stop it here itself. Personally, I believe we can start mTOR inhibitors here itself in the induction only. Though they act mainly in the maintenance phase, we can start them in the induction phase only because they act in the later phases of immune response. So if we start giving them early, if we start giving them late, there is no way the use can be restricted. The benefit because of mTOR inhibition can be restricted. So for that reason, I feel practically that mTOR inhibitors can be given in the induction phase. Whereas with respect to maintenance phase, obviously cyclosporine or tacrolimus are preferred. But these are highly nephrotoxic. If once nephrotoxicity sets in, we usually shift the patient to methotrexate or azathioprine or mycophenolate mofetil. Nowadays, what we usually do is, along with these two, as an add-on, we have started mycophenolate here itself. This is about organ transplant. Now, obviously, all autoimmune disorders like your rheumatoid arthritis, Wegener's, IBD, Crohn's, and all, so on and so forth. Now, one very specific indication of immunosuppressants is drug-eluting stents. In a bypass case, in a stenting case, we add stent which elutes Sirolimus. This helps in maintaining the stent patent for longer durations because no immune response will be seen at the site of stenting. Now, adverse effects. Basically, all immunosuppressants are known to cause increased opportunistic infections. Cyclosporine group of drugs, they are nephrotoxic. Your anti-cancer, anti-metabolites are bone marrow suppression. I think these are most important. I think I've concluded, I have covered all the points. Thank you.